Okay, it looks like it's top of the hour. Thank you everyone for joining us today for our webinar, and happy holidays to you and your families. Just a couple quick things before we get started. Handouts can be downloaded at any time during the webinar under the Handouts tab. And the evaluation will open in a separate window at the end of the webinar, so keep an eye out for that. And certificates will be available by logging into your account this Wednesday. Dr. Spatz, if you're ready to get started, go right ahead.
Fabulous. Thank you so much, Kim. Good afternoon, good morning, good evening, wherever you might be logging in from. I'm sure we have some people from some different time zones. I'm very happy to be able to lead this last webinar of the year, probably for Medela. This is about antenatal milk expression, a state of the science. I will tell you that I'm going to give you a little bit of introduction and background about myself for those of you who don't know me, and kind of how the study that I'll talk about even came to be to fruition. So for those of us who have not met, I am Diane Spatz. I am a PhD prepared nurse. I have a bachelor's, master's, and PhD, all from the University of Pennsylvania School of Nursing, so kind of a little boring in that fashion. I became faculty when I finished my PhD in 1995, which is just hard to believe that I've had my PhD for over 25 years now. I do share a joint appointment with Children's Hospital of Philadelphia as a nurse scientist with a focus on lactation and the Center for Pediatric Nursing Research and Evidence-Based Practice. I also am the treasurer and on the executive committee for the International Society for Research in Human Milk and Lactation. So if you're not familiar with that and you are a researcher, that is a great organization to get involved with. So again, to give you some context to this whole talk that I'll do today, I'm just kind of going to lay the groundwork for how and why it became about. So when I received my PhD in 1995, I started an entire semester course on human milk and breastfeeding for nursing students. When I went to Penn as an undergraduate nursing student, I learned absolutely nothing about human milk and breastfeeding. And when I finished my PhD, we got a research grant funded about human milk and breastfeeding, and it was an intervention study for mothers who have low birth weight infants. And that is really how it came about that this has been my whole career. The students at Penn are either junior or senior nursing students, and they have a 28-hour lecture class as well as 14 hours of clinical experience, and that is offered both fall and spring semester. That is of importance because my doctoral student now, who is doing her research on antenatal milk expression, took this course. So that's to give you some context about the Penn part of my job. I also teach throughout the curriculum at Penn, students in the bachelor's level, master's level, and PhD level. The course at Penn has been featured as best practice, but again, still few schools of nursing offer courses such as this. In 2001, I had been recruited to Children's Hospital of Philadelphia. At that point of time, CHOP had just one IBCLC, and they had just 4 breast pumps for the whole hospital. So I had been recruited there in order to develop a system-wide approach for lactation. The reason I said yes to going to Children's Hospital of Philadelphia really was because of the Center for Fetal Diagnosis and Treatment. So I have a master's degree in perinatal nursing, so I've always been passionate about high-risk pregnancy and high-risk infants. After coming to CHOP, we did open our own special delivery unit. So that's our birthing hospital for people who have babies with complex anomalies. And then I was also able to submit the paperwork and go through the process for Children's Hospital Philadelphia to be its own milk bank. And that opened in 2015. So again, to give you some context for the current study I'm going to be talking about at the end of the presentation, all of our babies who are born at Children's Hospital of Philadelphia have congenital anomalies. So we don't have any normal births at all. So this is baby Charlotte, whose family allows me to tell you about her always. On the picture on the right, you can see those are her two moms, and I met them before they gave birth. The birth mother is the lady in green. So they knew before the baby was even born that the baby would need multiple surgeries in order to get discharged from the hospital, and that the mother would be pump dependent for a very long period of time. And so these are the type of babies that I really enjoy working with, because with babies as such, human milk can be a difference between life and death. And human milk and lactation can change the life course, not only of the child, but also of the entire family. So the middle picture is of Charlotte direct breastfeeding. She did indeed transition to direct breastfeeding, and her birth mom made over 1 liter of milk a day for the whole time that the baby was in the hospital. The birth mom had so much extra milk that she was able to become a donor to the milk bank. And this was back before we were our own milk bank. So we had to actually collaborate with another Himbata milk bank and ship that milk out to them. So this is Lindsay and Charlotte today. Charlotte is now in double digits. She is beautiful, healthy, super smart. You'd never know that she was critically ill or sick. The only thing you would know different about her is that she doesn't have a belly button because she had an omphalocele. Her mother, because of the experience that she had at CHOP and of being a milk donor, when the Human Milk Banking Association of North America needed a new executive director, I recommended her for this job, and she is in that position. And Himbata has seen phenomenal growth in recent years. So human milk transformed the life of not only that child, but that entire family. So another reason to give context to this important topic of antenatal milk expression is that this year, the American Academy of Pediatrics released their position statement. It has been 10 years since it was updated, and they increased their recommendation to breastfeed not just for 1 year, but for 2 full years. And some of you may remember that the timing of this release really was not met with very good media reaction. There was a lot of negativity surrounding the recommendation to breastfeed for 2 years. Now, for me, I was very happy to see that recommendation because it brought us into the alignment with the World Health Organization, who's always recommended exclusive breastfeeding and then followed breastfeeding by 2 years. Unfortunately, with the new AAP position statement coming out, we have been dealing with formula shortages in the United States all year. And the same week that the new position statement came out, we also had the failure of the PUMP Act, which was the recommendation in Congress to expand coverage for all employed people. So instead of just hourly people being covered, also salaried. It would have expanded coverage to 9 million additional employees. And Congress said that they could not pass it because it would be too burdensome for people, employers, to be able to give people break time. So again, if you think about all of these things, you can understand that we're not reaching national goals or international recommendations for long-term breastfeeding. Earlier this year, the World Health Organization and UNICEF in February released a pretty startling report about the $55 billion marketing industry of formula companies. Now, the US was not part of the participants of that report, but the participants came from low, middle, and high income countries. And as you know, the World Health Organization has long been the biggest supporters of exclusive human milk and breastfeeding. However, very few infants worldwide are exclusively breastfed for the first 6 months, and breastfeeding durations remain very low in many countries. Again, looking at that report, they say that formula milk marketing represents one of the most underappreciated risks to infants and young children's health. And so again, thinking about the antenatal milk expression topic area, you can understand why people may be interested, because breastfeeding rates have only slowly increased in the past 20 years. However, formula sales have over doubled. So clearly, formula marketing is winning, okay? The WHO and UNICEF report compares the marketing of infant formula to be no different than the marketing of other unhealthy products such as tobacco, alcohol, and ultra-processed foods, all of which we pay sin taxes on. So we need to be aware of this report because it has significant implications, and we want to think about the fact that we really need to have everyone care about breastfeeding, not just people who are interested in the care of childbearing families and children. In addition, we have to also acknowledge and deal with the fact that the pandemic has negatively impacted breastfeeding. News from the AAP conference held earlier this year said there were reports of decreased breastfeeding rates, decreased exclusive breastfeeding rates, and we have seen this also in my Philadelphia area, and we have published some new research on this topic area as well. So with all of that being said, that really brings us to the topic today, and I'm going to get to antenatal milk expression just now because it falls back on my 10-step model that was developed based on the research that I did from 1995 to 2000 and my early years at Children's Hospital of Philadelphia. And what we're just going to be talking about today are really these first two steps about informed decision-making and establishment and maintenance of milk supply. We know that many people don't initiate breastfeeding because of a lack of support or education, and we know that this has gotten worse with the pandemic. So we have a new publication that came out earlier this year where we looked at families who were cared for in the Center for Fetal Diagnosis and Treatment. And we looked at 160 people who had prenatal consultations that were personalized one-on-one consultations that I actually was the person who did the intervention. And then we looked at their outcomes post-discharge. And here you can see the darker bar is our rates at Children's Hospital of Philadelphia, and the lighter bar are the comparison CDC rates, which are on healthy term babies. So you can see an initiation rate of 98%, any breastfeeding at 89%, Any breastfeeding at 6 months being 69.7%, 45% exclusive rate. Any breastfeeding at 12 months, 50.6. All of these are statistically significant higher than national data on healthy term babies. Very impressively, 1/3 or 34.4% breastfed over 12 months. So this is important because if we help people make informed decisions for human milk, and then we get them going with their milk supply so that they can both establish and maintain their supply, we will have people who provide milk long term. So thinking about in pregnancy, what do we teach to families? And it's interesting because just on Friday, I was lecturing for our midwifery students. And these are students who are going to be graduating in just 2 weeks. And I asked them, how many of you teach your people when they're pregnant that they're making milk in their second trimester? And only a few hands in the class had gone up, and they were all students that had taken my undergraduate course at Penn. So the messaging to families about the fact that no matter how early they give birth, they are going to have colostrum available is very important. Now, when we think about colostrum, it's also important to understand the purpose of colostrum is not meant to grow a baby or get a baby big and fat, but it's meant to lay down that baby's immunobiological system. Okay, and when we look at this bottle here of colostrum, that represents about a full entire day of feeding. Now, if you think about that and you think about the bottles of formula that hospitals have, the bottles of formula are huge. They're 60 mLs. Back when I was a brand new nurse, they used to be 4 ounces. So immediately you can understand how families think that there is a problem, that they couldn't be possibly making enough milk for their child when the bottles of formula are huge, and when hospitals often recommend supplementing at 30 mLs even on day of life 0. And this mismatch was well reported in that WHO report by WHO and UNICEF, the study earlier this year, where healthcare providers, and they interviewed 300 of them, actually reported beliefs that said they didn't think colostrum was enough for a baby. So very, very worrisome. We have a critical window to come to volume. That is secretory activation. Now that can only happen when both the baby comes out and the placenta, okay? And this is very important to remember because some proponents of antenatal milk expression believe that by doing AME, that people are going to produce more milk more quickly after birth. However, you really cannot have copious milk production until the placenta is out, okay? So the idea that it would speed up secretory activation may very well be unfounded because, again, if you think about the physiology of milk production, in order to go into secretory activation, we must have both the baby and the placenta be delivered. So the #1 concern of families all around the world is milk supply. And that concern about milk supply has definitely gone up in some populations since the pandemic. And because of this worry of milk supply, you have seen that there's been a growing interest in antenatal milk expression, right? So I just laid the groundwork for you, right? I talked to you about the fact that the AAP has increased their recommendations. I talked to you about the fact that WHO and UNICEF report that there's a problem because even healthcare providers themselves don't believe that there's enough colostrum. And we don't have the majority of people, according to the CDC, reaching the goals that we would like for breastfeeding, okay? So because of all these factors, you see people talking about antenatal milk expression. And in fact, if you go on TikTok, you will find information about antenatal milk expression on TikTok. Myself personally, I find that worrisome. So in a publication from 30 hospitals in Australia and 56 maternity centers in the UK, you could see that healthcare professionals recommended antenatal milk expression to 70 to 73% of women with diabetes, to 25% of women with high-risk pregnancies, and even in some cases, 19% of health professionals recommended it to every single pregnant person they met. So why am I worried about that? Because the clinical practice guidelines often do not match at all what is published in the literature, okay? And so these are instructions from NIH. I can't even talk today. Mid-Essex Hospital Services, the NHS Trust, okay? And you can see they have a whole lot of people that they're recommending antenatal milk expression for. And these are people that we don't have literature published about. So the clinical practice guidelines that are out there don't match the published research. So that is something we all should be concerned with. So that brings me to the beautiful Nina Genturiel. So you heard about the class at Penn. Nina took that course, that whole semester course, as a first semester junior nursing student. She said to me in class, she said, well, Dr. Spatz, what is known about same-sex mothers and lactation? And I said, well, I don't know. Why don't we look in the literature? And in fact, there had been nothing published at that time except for one very old article. So for N361, Nina did a case series about same-sex mothers and their lactation experiences. She went on to get undergraduate research funding for a research study mixed method on same-sex mothers and lactation. And she had 2 publications before even finishing her BSN. That should say BSM, not PhD. I had PhD on my mind. So she started her PhD immediately after graduating from her BSN. So we have a program that goes BSN to PhD. And she determined that her area of interest would be antenatal milk expression, which I will now refer to as AME or AIM. So she wanted to continue to look at vulnerable populations, which is why she decided to look at antenatal milk expression. So one of the first things she did starting her doctoral program was to start with a case series. And we did this because, as you'll see in a moment, a lot of the research about AME has been conducted outside of the US. There has not been much in the US except for one author, which I'll share with you momentarily. So because of this, we wanted to get the perspective of some US-based participants. And as you can see in this case series of 3 mothers who we interviewed, They were all doing it because they wanted to avoid formula or hypoglycemia for the infant, and there was also a case of separation. Interestingly, some of the participants too used a breast pump, which has never been published in the literature for antenatal milk expression. One then switched to hand expression, and the other just used a hand. They did 1 or 2 sessions per day, and they did it actually for longer than the recommendations in the research literature. And then you can see they had a varied amount of milk that they were able to get during pregnancy, between 1 and 15 mLs, and they stored it in the freezer. So after that case series, that led Nina to start her integrative review for the topic. And this is kind of part of what you do when you get your PhD. You will do a state of the science on a topic area. And so this has been published, and it goes through the 15 worldwide studies, and it looks at the outcomes for mother infants after birth. And one of the major things that is found in that state of science is that there's really not good quantitative measurement of milk supply in most of the research, okay? So one thing I want to start with before I go on with this topic area is the fact that AME is different than nipple stimulation. And this is in our case series publication, okay? This is always one of the big concerns when you talk to OB healthcare providers, that they worry that if someone participates in AME, that they are going to cause contraction. But it's very different to do AME than it is to do nipple stimulation, okay? So it's super important to understanding the difference between AME and nipple stimulation. The way that AME is completely different than when people are doing nipple stimulation for labor or contraction stress testing. So with an integrative review, the recommended way to do that is with the Whitmore and Knapple method. And you go through and you select your articles, and this is our Prisma diagram from the literature review. And then you should rate the level of evidence that you are reviewing, as well as appraise it for how well that research kind of is described. And so the publications, as you can see, by far most come from Australia with 6, 4 from India, 1 from New Zealand, and 2 from the UK and the US. So I'm going to go through and talk about these different areas of research. So kind of one of the first publications was this pilot study that came from Australia. So this group of researchers in Australia is interested in the topic of antenatal milk expression for people who have diabetes, okay? So this was the precursor to the DAME study, all right? And so in that precursor, they had 49 participants, all with diabetes. Again, this was conducted in Australia. So think about the healthcare system in Australia. It has a midwifery model of care, very different than the US. And they, in the DAME pilot, had participants express on average for about 14 days prior to giving birth, okay? So that's the major finding from that piece of research. So it was different for different families in terms of how much milk they could get. But that is one of the few articles that kind of even reports about antenatal expression and volume. So then we go to the Dane study, and the Dane study is the largest randomized controlled trial and the only randomized controlled trial on the topic area. There were 635 women recruited and randomly assigned, 319 to the antenatal expression, and 316 to standard care. Okay, they did not find any negative outcomes from participating in AME, and they did not say that there was any harm. In this largest RCT, they recommended to express using your hands no more than twice per day for 10 minutes. So 5 minutes on one breast, 5 minutes on the other breast, that would be one session. And then 5 minutes on one breast and 5 minutes on the other breast, and that would be the second session. And they began this intervention at 36 weeks gestation. Now, our next piece of research, also from Australia, was just a small study of 12 women. And this was a qualitative study, and it was just 12 participants, again in Australia, all of whom started AME at 37 weeks. So from that small qualitative study, they reported that many women were very positive about the experience because it allowed them to get to know their breasts and gave them a sense of security by having colostrum stored. But they did not report anything about volume. The main negative effects they found were a sense of embarrassment in expressing the colostrum, especially if there were other people around, and some discomfort with actually doing it. There was one person who actually reported some pain. The last qualitative from Australia had only 6 participants. So again, very, very small. You can see this again was looking at people with diabetes. So that's a common theme. And there was not really much in terms of critical findings from this particular study. And again, such a small sample size. And then they have a retrospective cohort study from Australia. Again, this is all participants who had diabetes in pregnancy. They had 80 women who had expressed antenatal colostrum and 223 who did not express colostrum. Some positives that they found were their babies were less likely to get formula for the people who expressed. They also had a fair amount of missing data, and they also did not report any volumes of milk. And then one more retrospective cohort study from Australia, and this is very interesting because it was done at a baby-friendly hospital. And they had 3 different groupings of participants. So they retrospectively audited medical records of 294 women. And they did it at 3 different time points. A group of people who had done the practice before BFHI, then a group with AME instruction, and then a group that had AME instruction and baby friendly. And they did not find any differences in formula usage or admission to the special care nursery. So again, reinforcing that it is a safe procedure, but still not telling us the full story. Now, there is one unpublished thesis from New Zealand, and this was just on 10 participants, and these two were women who had diabetes. This particular publication has not yet ever made it into PubMed. I have been looking for it. The one thing that's important to note about this unpublished thesis is that it is the only one of the 15 studies where they had participants start at 34 weeks gestation. Moving on to the United Kingdom. So this first study from the UK looked at women who had received advice from healthcare providers about doing antenatal expression. So 37% of families had been advised to express antenatally by a health professional, but only 16 out of 94, or 17%, actually did so. So again, no information provided about milk supply. One has to think whether or not people are getting enough information to do this practice. And this was a cross-sectional survey across the UK, 688 people. 64% had heard about AME, 14 had undertaken it. Some people thought it might not be a good idea. One interesting finding was that participants who had a high BMI were significantly more likely to have heard of it. But again, they didn't measure whether or not people did it or anything about milk supply. So now we move on to our two US-based publications. These are from Jill DeMercy-Ratke. She's actually a PhD nurse who I have known and mentored in the past. She is out at the University of Pittsburgh. And so Jill has two publications. This first one was a case series. She looked at 4 participants that had been part of a larger study. And these were people who had late onset preeclampsia. And again, we don't really have any measurement of milk supply with this case series. And then Jill's second publication is about 19 subjects who were, again, in the US out in Pittsburgh. And they did a semi-structured interview about 1 to 2 weeks after birth about their experiences. And they, in this particular research, initiated AME at 37 weeks. And just like the quote of the title, it gave me so much confidence. This was perceived as a positive thing for participants. Interestingly, she said in her paper that some of the participants found that birth hospitals were unsupportive. So again, gives us some more information, but these were only first-time mothers in her research. And then from India, there are 4 studies. They're all pretty much the same in what they do and report. They were all prospective cohort studies. They all initiated AME at 37 weeks, and all of it was just self-report data. There was no objective measurement. So common themes in the research. Start AME at 36 to 37 weeks. Again, there was one outlier. I would ignore that one. Different protocols, 1 to 2 times a day, twice a day, 2 to 3 minutes, and no more than 5 to 10 minutes per session. common themes in terms of the parent and what they found, if we looked at all the studies, an improvement in self-efficacy and confidence, having security that they had colostrum available, and presumed secretory activation, though not measured objectively through any lactation biomarkers or anything like that. Themes for the infant were no increase in preterm or NICU admission, improved glycemic status for the ones that looked at diabetes, and that positive ability to provide the milk to the baby at birth. So to wrap up the webinar today, I will now talk to you about our current study at Children's Hospital Philadelphia. This is Nina's dissertation research. It's quite exciting. It's very, very cutting edge. It's going to change the world, as I keep telling her. And I am Nina's PhD supervisor for her work. So these are the primary aims of this very impressive dissertation: to examine participants' willingness to adhere to an AME protocol, to look at the participants and how much they can actually collect, so measuring that antenatal expression, and then also measuring the milk supply after birth. So looking at the first 14 days after birth to see the onset of secretory activation as measured by both milk volume and lactation biomarkers. So we are collecting both sodium and lactose, and that allows us to actually see true onset of secretory activation. So this research is done at Children's Hospital of Philadelphia in the Center for Fetal Diagnosis and Treatment. So as I mentioned, all of our families have a baby with a known congenital anomaly. None of them are normal, and the parents are in general pump dependent after birth because their babies are critically ill. One of the things that is very interesting about the CFTD and CHOP is that we have a standard of care that is both maternal fetal medicine as well as midwifery. And again, we have published about this midwifery model and looking at our group prenatal care, where we looked at, we had the participants in our mama care, which is our modified group prenatal care. 100% of them did initiate milk expression for their baby, and 87% of them were providing milk at time of the baby's discharge from an ICU. So this makes for a great study setting to do a study on antenatal milk expression. So the participants have to be pregnant, over 18 and English speaking, planning to give birth at CHOP, and planning to have a baby that would get delivered close to its due date. They have to have intent to provide milk for their baby, have had a prenatal consult at CHOP for lactation, which again is something we've published about, have access to a smartphone or personal computer and the internet to fill out their data collection forms, and access to a freezer at home to store their expressed milk. The people who are excluded from the study are people who would not be able to provide milk per the AAP, so things like HIV, HTLV 1 and 2, etc. If they had a known history of abnormal breast tissue development or breast surgery, because they would not come to volume normally. People who have a delivery or birth plan prior to 37 weeks, those who are at risk for preterm labor, for example, a baby with a myelomeningocele who's had fetal surgery or multiple gestation, any history of antenatal hemorrhage or placenta previa, any history of reproductive technology, history of gestational diabetes, because we know that can impact coming to volume, and then any other serious issues. So once we see the patient, we do the HIPAA authorization and informed consent. We then collect basic demographic information, okay? And that occurs by 36 weeks. The parent is taught AME through video demonstration and teach-back methods, and they're taught how to label and store their milk at home until they come in to give birth. So we look at whether or not the person adhered to the AME protocol. So did they do it twice per day from 37 weeks, which is when they started, until they give birth? It's a yes, no that they fill out. And then there's a space for comments about their expression session. And again, they're doing this by hand. And then they also take a photo of their colostrum, and this is also verified by a log. Post-birth, because all of our families are pump dependent, it is very easy for us to collect the milk volume data. We have a standard family pump log that is part of our care. All of our families are accustomed to doing this. So after birth, the parent actually takes a picture of the logbook and submits that via REDCap until they are at day 14 after birth. So we can calculate the amount of milk per 24-hour period. We look at the frequency of pumping post-birth and the milk volume per 24-hour period from birth until day 14. And then again, very importantly, that has not ever been done before, is we are collecting lactation biomarkers. So the sodium probe is done at point of care, and then the lactose, we collect a small sample of just about 2 mL, and that is frozen, and Nina will get to go over to the University of Western Australia and learn the analysis of the milk with Dr. Donna Geddes. So this is really very exciting. So what can I share? You do not have these findings in your handout, and that's because this is unpublished data. So I can't share unpublished data with you. So please don't take a screenshot or a picture of it. We're about a third of the way through recruitment and data collection. Recruitment has been a little slower than anticipated due to people transferring care too late or people planning to give birth early. We've also had some difficulty with scheduling and making sure people had their prenatal lactation visits scheduled before 35 weeks so that we had the opportunity to screen them and then enroll in the study. So we're a little slower than I had anticipated, but it's also been very positive because once the participants hear about the study, most of them are interested. So most of them don't decline us. About half of our sample are pregnant with their first child and about half are multis. The participants mostly adhered to the recommended protocol. Again, our protocol was to do it twice a day, 5 minutes on the right, 5 minutes on the left, and again, another time of the day, 5 and 5. There were a couple people who didn't get to do it all on certain days, and there was one person who did 3. 5 subjects have participated from 37 and 07 weeks to 38. So that's when they were giving birth, and 6 did it for 2 weeks. The really very exciting news is that every single person has been able to collect and store milk for their baby. Range of 0.2 mL being able to be collected during pregnancy up to a whopping 27.48 mL. And I can say that the participants just have loved being in this research. It's just been so absolutely rewarding for Nina, myself, and for the families. 24-hour milk supply on day 0 ranged between 0 and 41. By day 14, the range was 383 to 1,381. So the majority of people did come to full volume. Volume attainment ranged from day 1 to day 4, and day of coming to volume ranged from day 3 to day 8. So we actually do the sodium probe at point of care. And if you remember, sodium is only high in colostrum. And then on the onset of copious milk production, it drops rapidly. So Nina actually is so skilled at this, is like, she can actually know when that sodium is going to go down by working with the parents and looking at their milk. But then she has that validation. She sees that with the probe. It's been so fun and exciting. And then the milk samples that will get analyzed at UWA, those little tiny samples of milk are being stored in the HMMC. And those samples go from day 4 to day 7 after birth. And it's just a tiny amount of milk from the left breast and the right breast. And then once Nina finishes enrollment and data collection in the US, she has received research funding to travel to UWA in 2023 and will be working with Donna Geddes. Nina and I were lucky that she's had 4 different sources of funding. She received a research grant from Children's Hospital of Philadelphia Metabolism, Nutrition, and Physical Development Center. She received funding from the National Association of Neonatal Nurses. She received funding from our Hillman Scholar Program. This is our BSN to PhD program at Penn. So if any of you are interested in your PhD. And then she also received funding from the International Society for Research in Human Milk and Lactation, which I mentioned, I told you earlier, I am the treasurer of that. She received a trainee travel grant through Ishmael, and that's going to allow her to travel and study with Donna at UWA. So I believe I left us about 8 minutes for questions. If you are interested in any of my references from this publication, or if you're interested in bringing my 10-step model to your institution, that is my email, spatz@nursing.upenn.edu. And you can also see one of our infographics that we developed during the pandemic about the 10-step model. So at this point, Kim, if there are any questions, I am happy to entertain them.
Yes, thank you, Dr. Spatz, for that presentation. That was amazing. And I wish Nina well on her research that she's doing. That will be excellent to hear the further outcomes of that. We do have about 8 minutes for questions, and they are coming in. To submit a question, you can do that via the questions panel. The first question that we have is the secretory window the same in premature and term babies?
So yes, absolutely. You know, again, when you think about a person giving birth, we have to have delivery of the baby, delivery of the placenta, and that's what's going to cause secretory activation. Now, there are researchers and clinicians who say, oh, mothers who have preterm babies, they 100% will never come to volume effectively. And that is not necessarily true, because if someone is really expressing early and often, they may be able to follow that same window of coming to volume. We do have lactation biomarker data from some US and Canadian based researchers, Rebecca Hoban, Paula Mayer, where they had looked at preterm births, so people who gave birth early, and they measured their lactation biomarkers. And the people who had the normal lactation biomarkers were the people who pumped more. So they pumped more frequently and more often. And that led them to have these normal biomarkers. So again, standard of care for anyone who gives birth and is separated from their child should be this idea of pumping early and often. So pumping within the first hour, the first 6 hours, that first 3 to 5 days is a critical window. So really understanding that we need to have that effective stimulation to the breast if the baby is not able to feed. And all of our parents are pump dependent, so they're initiating with that hospital grade computer chip pump.
Okay, thank you for that. The next question is, I work in a NICU and constantly fight physicians expecting babies to take 30 to 45 cc's at 24 hours of life when bottle feeding either EBM or formula. How do you handle that unreliable and potentially harmful expectation?
If we could solve that problem, this is what I can tell you though. We have in place at Children's Hospital of Philadelphia a clinical pathway guideline that really protects over supplementation of babies. So we actually provide guidance that if for some reason a baby needs supplementation early on day 0, day 1, that it's those small amounts of colostrum, 5 mLs, 10 mLs. I would recommend that you utilize the Academy of Breastfeeding Medicine's supplementation guidelines. My only caveat with those guidelines is they give a range of supplementation, and I think some of their numbers are that in the range, the high-end numbers are a little bit large. So I take you back to that Santoro slide that talks about the normal range of colostrum production, being on average just less than a half of an ounce. So when we're thinking about a per feed supplementation, we really want to think about, very small amounts of supplementation being provided. And the other thing I really emphasize to clinicians and parents is that if someone says the S word to a parent, meaning supplement, we 100% have to say the P word. We have to get them pumping. And again, my preference for that would be that they would be pumping with computer chip technology that mimics how babies drink colostrum.
Okay, thank you for that. Looks like we've got about 3 minutes left, so we'll try to get to as many questions as we can. The next one is, if AME is indicated to collect colostrum from mothers with GDM, why exclude this population? Many have full milk volumes.
Well, in this particular research study, we are looking at lactation biomarkers. And we know that when people have diabetes or GDM, they often experience a delay in secretory activation. That is the rationale of why we had to exclude them, because they would not follow the normal curve that people without diabetes would have. So yes, they may eventually come to full volume, but you'll see a delay in secretory activation. So they would mess up all of our biomarker data. So that's why they're being excluded. Remember, there is research, including the Dane study, where they are looking at doing this practice because they want to avoid supplementation. And one of the reasons supplementation happens with infants of diabetic mothers is because they are often LGA, they get hypoglycemic, and their mother has a delay in secretory activation, thus leading to that formula use. So we had to take them out of the mix for this particular research.
Okay, thank you for that. It actually looks like we're almost at the top of the hour. So just a couple quick things before we end the webinar today. Thank you again, Dr. Spatz, for presenting this great information. And evaluations, this will be opening up in a separate window after we end the webinar. So please make sure you fill those out. Your certificate will be available by logging into your account this Wednesday. And registration is now open for our January 25th and our February 15th webinars. You can register for those at medilaeducation.com. And we want to wish everyone a very happy holiday, and we will see you in 2023. Thank you.
Thank you, everyone.